All right, welcome everyone. It is Friday, August 23rd, 2024. This show is going to be a great one. Welcome to the Florida EMS webinar, where myself and Tanner Smita host incredible folks every single week. We try to stick to folks who have published research in the EMS field. This came to me because many of us know Scotty Bolitar, Stephen Rahm, David Miramontes, the folks in San Antonio who we all look up to. And Scotty and I were texting, and he said, "You have to see this paper that we just published." So I read it, I saw the video, and then I reached out to Dr. Saab, who's going to be our speaker today. And he said, "Yes, I would love to present." And so here he is. So what I would like to do is turn it over to you, Matthew, if you can make a further introduction and then take it away. Thank you so much for joining us today.
Thank you, Dr. Antevi. Well, like you said, my name is Mathew Saab. I recently completed the Brooke Army Medical Center Emergency Medical Services Fellowship. It was 2 years in San Antonio where I worked with Dr. Miramontes and many of his EMS agencies down there. And I also got to participate in this research that I'll be presenting today. And like he said, that was in collaboration with Scotty Bolitar over at the Center for Emergency Health Sciences. My contact information is here, and I will also put it up at the end in case anybody wants to contact me later offline. But today we're going to be talking about the paper that is Mind the Gap, a novel protocol for improved vascular access in a hypotensive patient. And here the logos are just the institutions that we collaborated with on this. I do want to let you guys know, disclaimer up front, everything that I'm going to be talking about are my words and not the words of the Army, the Department of Defense, the government, or UT Health slash UTSA now, as they've joined. What we'll talk about today is the background about why we did this, what our idea was, why it's important, what happened, what were the results, what they mean, and then I think we'll have a discussion about what they mean and get further down to the nitty-gritty. What my goal is that everybody here will be able to understand GAHP and the theory behind it. We'll be able to answer all of your questions, and you'll have an idea of what I had been doing in my downtime. As some background, I think everybody who's worked in healthcare, and certainly everybody who's worked in pre-hospital medicine, can attest to vascular access can be very difficult in certain patients, particularly those who are hypotensive or critically ill. Specifically in trauma patients, when they're experiencing vascular collapse or they have such a high adrenergic state with vasoconstriction, vessels will often get tiny and the target becomes small. So getting access in these patients becomes difficult. One of the things that spurred us to look into how we can better vascular access in these patients was a paper published by Ryan Dumas et al., Moving the Needle. It was an East multi-center study where they compared central IV cannulation, peripheral IV cannulation, and intraosseous cannulation at multiple centers, multiple trauma centers, and video recorded the operators. What they found was that placing an IO was just as fast as a peripheral IV, if not faster, and had higher rates of success. So in talking with Scotty Bolitar, he had this idea, how can we improve vascular access in these patients? Well, as you can see here, what we have is a radial IO, and we also have a fluoroscopic image of that IO. You can see that the intraosseous line is innately connected with the vascular beds. So if you infuse something into that intraosseous line, it should go into those vascular beds. And what would happen if we infused a bolus? Could we leverage that bolus to optimize the anatomy of adjacent veins to make them bigger, in a sense, or engorge them to improve vascular access options? So the idea became for a graduated, we call it GAHP, the graduated vascular access for hypotensive patients. If we take a distal IO, infuse fluids through it, increase or engorge the veins of the proximal vessels, can we then facilitate and make it easier to establish vascular access? And a lot of people might say, well, why would you do this if you already have the IO? Why would you need a vein? And particularly in rural EMS settings where you're participating in prolonged care, or in military settings where you're doing something like that. Getting the IO is great, but if you have to sit on the patient for a long time, or infuse more rapidly, or get a second point of vascular access, this is the idea of where this process could be advantageous. So how did we test about whether or not performing GAHP is going to optimize these vessels? We took 23 cadavers. They were going to be used for other research and training procedures. And we used 3 different types of IO needles that were all available to us to see if this would work in all 3. And we took the life flow device, which I hope everybody's familiar with, but I'll show a picture of it if you're not. It's essentially a hand cranked or hand pumped syringe pump. And we used ultrasound in real time in the cross section to measure blood vessel diameter, blood vessel circumference. This is what it looked like. And up at the top, you can see the life flow device that has a syringe in it, where it pumps fluids through the extension tubing. And to the right, you'll see what it looked like as we collected data. We were measuring in real time the blood vessel circumference pre and during fluid infusion to see how big it would get, or how small it would get, or if there would be no change. So could we augment blood vessels to better facilitate vascular access by pumping fluid through an IO? We thought that we would. And we selected 4 sites to look at. We wanted to look at the axillary vein and the cephalic vein in the upper extremities, and the femoral vein and the saphenous vein in the lower extremities. The reason that we looked at these sites were we wanted to do both central and peripheral vessels. And a lot of people will probably say, well, the axillary vein is not a central vein. And that's correct. But the subclavian vein is technically difficult to ultrasound and measure. And the only difference between a proximal axillary vein and a subclavian vein is about 1 centimeter of difference from whenever it becomes deep to the clavicle. We also looked at both central and peripheral vessels because not everybody is used to or has the ability to cannulate central vessels. So in a prolonged care setting, if you could establish a distal IO in the leg or in the forearm, you could then potentially cannulate a cephalic vein or a saphenous vein. And this is what it looked like when we were measuring our data. If you look at image A, you'll see a radial IO having been inserted, and image C is the corresponding circumference of the cephalic vein measured in that extremity. In image B, you'll see that IO while crystalloid was being infused through it. And in image D, you'll see the circumference of the IO pre and post being 0.46 centimeters and 0.99 centimeters respectively. And I'd bring your attention over to the forearm in image B of this cadaver, where you can see that the superficial veins have actually been engorged and are much easier to both see, palpate, and potentially cannulate. So the things we were looking at was 1, circumference, which we talked about. 2 was volume. We wanted to know how much fluid would it require to pump up these vessels. And 3 was the time. How long did it take to optimize them? Optimizing was defined as the maximum circumference that they would potentially get while fluid was being infused. We did some statistical analyses that basically went like this. And after performing these, the output became, let me to move the camera, or sorry, I need to move the videos of everybody's faces so I can actually see the screen. In our first outcome, vessel optimization defined as the circumference of each vessel. You'll notice I'd bring your attention to the right column where the percent difference in the cephalic vein was 227%. In the axillary vein, it was 163%. In the saphenous, it appeared to be infinity because the the pre pre-infusion circumference was typically 0, meaning the vessel was flat. And in the femoral vein, the difference was 169%. I put in the left the IO site and the corresponding vein site. We did both sides of the body, and the picture that I showed you earlier, or the graphic, was just an example of left side upper extremity and right side lower extremity, but we flip-flopped each cadaver. In our secondary outcomes, in volume and time, you'll notice that the volume was generally very low, less than 100 milliliters required to achieve optimization. And the time was generally very low too, typically less than 20 seconds. So what does that mean to us? Well, it looks like the larger vein size was associated with improved direct vascular cannulation attempts in previous studies. So if we could achieve larger vein size, then maybe we could facilitate this vascular access. That was not specifically studied in our study, however. In our study, though, every single vein that we targeted had an increase in circumference with a fluid bolus. So it's non-discriminatory. It happened in both central and peripheral vessels, and potentially could facilitate both central and peripheral access, step up to central and peripheral access. And then the last thing that I wanted to show to you, which I already mentioned, was that the vessel optimization was generally pretty quick, less than 30 seconds. So we may provide safer, less stressful, and more stable peripheral and central veins if we perform GAHP. That's because typically whenever you have a prolonged transport or you're treating a patient in the field, the IO that's sticking out of the patient is usually less stable, especially in helicopter or HEMS transports. If you move the arm, it could dislodge a humeral IO. If you brush up against the IO, it could become dislodged, and then you'd end up having an extravasation. But if you could get a peripheral access or a central access direct into the vein, it may become a more stable vascular access option for prolonged transports and prolonged care. But in our data, there wasn't any significant difference between infusion sites, and there was only a significant difference amongst the volume of fluid that was required to be bolus to achieve optimization. And that was in the saphenous vein, looked like required less, and that may be because it was a smaller vein, and you could imagine that a larger vein might require more fluid to optimize. Is this relevant to you? That may depend on where you're working and what type of patient you have. Certainly, I would not recommend performing this this procedure until we've studied it in alive humans. But also, I wouldn't recommend doing it if you have a very short transport time or if your patient isn't critically ill. The idea is that in those critically ill, long transport patients, when you need to step up your vascular access, have more vascular access options, have more stable vascular access options, this is where the GAHP procedure may be beneficial. So specifically for the military, where we're looking at probably a lot more prolonged care scenarios in the next conflict, and even those that we've already needed to undertake, sitting on a patient where you're trying to resuscitate them and keep them alive so that they could receive medevac, you may want to consider this as an option once we further study it. It could be, perform as a bridge to more definitive vascular access for these patients. But there are, of course, limitations to what we looked at. One of them being that this was performed in cadavers. We have not studied it in live tissue or in live humans. We have not proven that this is leading to faster vascular direct cannulation of vessels. We have not proven that this is leading to easier direct cannulation. But we are, though certainly there's some conjecture that this may be a way to achieve those things. And actually, my team is looking into doing that next. So we didn't um, we didn't look at time. We didn't look at number of cannulation attempts or ease. We're considering an animal trial for this. And um, the last thing I want to say also on this was that we used normal saline in the study. We did not use blood. Anecdotally, I've used blood on expired blood in this, and it did seem to work just the same. I do want to provide a special thanks to my collaborators. We had several of them, and some of them may be on this call, but big thanks to them. We wouldn't be able to do it without them. I also wanted to thank those who donated their body to our research in the UT Southwestern Willed Body Program, as well as the Center for Emergency Health Sciences for providing their facilities. And thanks to you guys for inviting me to speak. Thank you to Dr. Antevi and to Tanner. And thank you all for listening. I have several references. And I will take questions. I do want to say, if you have not read the paper and you'd like to, it's open access, so you should be able to get it for free. However, my contact info is at the bottom. If you'd like to email me, I could send it to you, or I could send it to Tanner or Dr. Antevi, and they could potentially distribute it to you all. I'm not sure.
And I see Tanner just put it into the chat. Mathew, this is an incredible presentation. Yourself and then the list of co-authors you have, pretty impressive group of people. I have so many questions, and I also want to mention some of the commentary that came across on social media, because everyone on this call today, obviously, we're in the field, we're in the business of, mainly critical care. We've all been there where we haven't been able to get vascular access. So this topic, I think, is especially beneficial. And I'm hoping the people on the call today, I see Kim is already raising his hand. I'll get to Kim in a minute. I'm going to go to Tanner first. But my question is, you said it took about 25 to 30 seconds to optimize the vein. How long does that vein stay optimized? Or does someone have to start that IV and cannulate as someone is using the life flow in this particular case? Can you comment on that?
Absolutely, yeah. And we didn't measure that in the study, but I will say, at least in the cadavers, when we were watching on the real-time ultrasound, you could think of the circumference as while it's growing, as being kind of undulating, where you see like an uptick in the size, but then it kind of fell when the pressure fell as the life flow was reloading or recharging with more fluid. So I would say, if you're going to be performing it with the life flow and everything as we did in this study, I can't say what would happen in a live patient, but I can say in the cadavers, the circumference would decrease rapidly, but not fall immediately to zero. And I can't give you the exact time, unfortunately, because we didn't measure that. But in performing this on the cadavers, yes, the increase in circumference did fall once you stopped pumping the fluid.
Can you give us what would you say just on the cadaver? I get that it's not in humans, but was it within 30 seconds? Was it within a minute? Because I think that's important as people are thinking through this. Yeah.
Yes, I would say when we were doing this in the cadavers, that maximum circumference would stay for a few seconds, and then it would start to fall rapid. So it would rapidly begin to fall, but not necessarily rapidly fall to zero. And it never really fell to zero when we were doing this. Actually, it didn't at all. But you could think of like a balloon with a hole in it, slow, or like an air mattress, kind of deflating would be how I would liken it. And I would say that significantly within 30 seconds, the circumference would be much lower and would actually, render the whole process probably ineffective. But if you're able to pump it up with a life flow with like a single operator, and then try to perform this, if you could get access within, a minute or 30 seconds, once if you can see like a superficial vein, you could probably perform this as a solo operator, but that peak circumference won't still be present. It'll still be inflated more than baseline, but that peak circumference won't be available.
Got it. Awesome. All right. Let me pitch it over to Tanner. Tanner, what do you got for Matthew?
Yeah, just one comment about the conversation that was just going on. I noticed also in the methods that you didn't use like a tourniquet like you would use to start an IV. That
No, we
might be
did not.
in the upper extremity. If
Yes,
you put a tourniquet on, you could keep the pressure elevated after infusion of some fluid.
I think that's a great idea, Tanner. And I think that we didn't do that in the cadavers, and it would I would I would hypothesize that it would change um, the outcomes if we did potentially improve them. And that does kind of remind me, actually. I don't know if anybody follows Anand Swaminathan on his Instagrams and socials, but I think just last week he was talking about maybe it was this week, a very similar process or analogous process where he basically said if you take like a small IV, like a 22 in the hand, and then put a tourniquet on the arm and infuse a 100 cc bolus or 200 cc bolus, something like that, then you'll plump up the superficial vessels in the arm, and you can do essentially what we're describing here. The reason we're describing it this way is sometimes you can't even get that hand IV, and IOs, at least in the moving the needle paper, are potentially should be first access option for these types of patients, the critically ill trauma victim. Maybe we shouldn't even be mucking around with direct venous cannulation as a first option, but maybe going to IO to initiate their resuscitation. And in this case, not only initiate their resuscitation, but also facilitate further vascular access concurrently.
Awesome. And then let's go to Dr. Kim Landry in the Panhandle. Kim.
Yeah, actually, the question was answered. I was wondering if a constricting band proximal to the extremity would require less fluid to be pumped into that extremity and hold it in the extremity longer than without it. And I think that was addressed. Thanks.
Yes, yeah. I can't say for certain. I would imagine that it would. However, the reason we actually didn't do it was because this idea of GAHP, like I said, could be potentially not simultaneous resuscitation and facilitate further vascular access procedures.
Awesome. All right. I see we have a lot of great. Oh, Tanner, you want to go ahead?
No, I just had a few comments to make, and then I did have a couple additional questions as well. So
Go.
I think when you're talking about kind of the usefulness of this on the civilian side of EMS, you've talked about kind of stability. It's a more reliable line, maybe less risk of dislodgement, that sort of thing. But I think also in terms of pharmacology, when we're giving lipid soluble drugs like amiodarone, right, IV administration might be preferable to IO access, as well as vasopressor administration. So, I know from animal models, we know that if you give big cardiac arrest doses of epi, IV versus IO, you see big hemodynamic responses and vasoconstriction and kind of what we want to see. But I think the verdict's still out when you're giving, small doses of vasopressors, push dose pressors, or doing vasopressor infusions, especially for drugs that have a short half-life like epi. The effectiveness of these medications, IO versus IV, I think is questionable.
That's an excellent point. Sorry, go ahead, Tanner.
No, you're fine. If you want to comment,
I was going to say that. Yeah, that's an excellent point. We did mention that, I believe, in the discussion, talking about different types of drugs being given IV versus IO, and specifically ACLS slash cardiac arrest medications may have better effect if you're giving them IV than IO. Mentioned that, but I'm glad you brought that up because that's also another thing to consider whenever you're in relation to this process or procedure.
And Tanner, before you make your next comment, I will say that we actually just modified our protocol specifically for amio, for shockable rhythms, to actually preferably, we didn't say you must, but we now say preferably IV because of the two papers that have shown quite clearly, in my opinion, the benefit of IV versus IO. But great point, Tanner. Go ahead.
And I think also, a lot of people on this webinar are either physicians or nurses, people that work in the hospital. I think this has a lot of generalizability to kind of the trauma bay, right? And so if you have, and I've noticed at least when EMS brings in patients with IO access or even IVs, I think whenever you're transferring the patient from the EMS stretcher to the hospital bed, oftentimes IOs, IVs, all of the kind of extension sets get disconnected out of fear of kind of dislodging access sites during movement. And so I think, if you're an attending physician, or if you're, directing your resident to start a central line, or if you're a nurse that's kind of involved in preparing for this procedure, reconnecting a line and pressure infusing some fluid kind of while that attempt is being made might improve success. And that could be an area where this drives practice change. And then also related to that. Oh, sorry, go ahead.
Good. I was just going to say, I'm really glad you brought that up, because I think like I said, the environment that you're working in should be driving whether or not this would be applicable. Should we, say that it helps in living patients? Because the way I first saw this going was the prolonged care patient in the military. Sure, we talked about that, but also, a long transport, and let's say like New Mexico or something, that may be a good idea of where to do this. And then, like you said, it may not be all done by the first half could be done by EMS if this is a quick transport ill patient in an urban setting. EMS starts the IO, starts the resuscitation, patient gets to the trauma bay, using that IO to upstep the access to another IV or to a central line would be the next step, and that could be performed by the people who work in the hospital. So I didn't foresee this as being only EMS or only hospital doing this, but that it could be a kind of a collaborative effort. And sorry to cut you off again, Tanner.
No, you're fine. And I'm sorry, Dr. Miamanis has his hand raised. So I'll give you 3 rapid fire questions. You can answer whichever ones you want, and then we'll move on to him. But so first of all, you use the LifeFlow infuser for this, right? So you're high pressures, you're using that syringe pump mechanism. Just from kind of your sense working with the model, if you just squeeze a bag alone, do you still see engorgement of the vessels or no? So that's the first question.
So
yeah, go
ahead. Anecdotally, did this with pressure bag because not everybody uses the LifeFlow. Did this once, and yes, that was an N of 2. We did it on 2 limbs, and both of them increased in circumference. But that's not really valuable data to publish, so I didn't publish that. But similar to the blood, did blood in 2 spots using LifeFlow and bag, and did normal saline in 2 spots using LifeFlow and bag, and both of them increased circumference, similarly to how we did with just the normal saline and the LifeFlow.
Now, also, like with cardiac arrest patients, right, with the rise of ECMO, we're not interested in just placing venous cannulas, right? We want to put arterial cannulas in as well, especially in, you're working with a cadaver model. After prolonged cardiac arrest, patients are pretty kind of vasoplegic. So the arterial side might mimic the venous side in terms of distensibility. Do you see any engorgement of the arterial side? Were you able to assess that in this study via ultrasound or not?
I don't remember seeing any meaningful engorgement of the arteries, but potentially I do see Steve Rahm is on, and I would punt to him. I don't remember if he does. We didn't measure it, but anecdotally I can't remember. Steve?
Yeah, we did not measure change in arterial diameter or anything like that, Tanner. But it's an excellent question, though. But unfortunately, that was not something that we studied or measured.
We'll go to Dr. Miramanis now.
Yeah, real quick. So I'm a recovering nurse, and back in the day, we didn't have ultrasound to do IVOs, and so we would use the RIC catheter, the rapid infusion catheter, a lot in the trauma bay. And so this is a great way to make that more successful. So a RIC catheter is you put a small 20 gauge, throw a wire in, you cut the skin, and then you advance the dilator and catheter combo over the wire using a Seldinger technique into the brachial vein. And then you got a freaking garden hose to give blood or whatever. So this would make that even easier, especially if you put a tourniquet on way up high by the axilla. And this is a great way that perhaps rural wilderness folks could potentially get good IV access without having to go through central line or ultrasound or anything like that. This might be a bridge for them to get a big honking hose to give blood or fluid or whatever. So just bringing that out. My recovering nurse, I twitch when I do that, came out of me for a minute, but that's where this could be applicable for that environment. This is not for the urban world. where you can go 10 minutes to an ER.
And that was one of my questions. A great comment. So I have two questions, Matthew. Is this, in your opinion, is this ready for prime time for people who are watching this webinar to go do it today on their patient in the ED? That's question number one. And then question number two, pediatrics, right? I mean, is there any reason this wouldn't fit the bill for kids?
Sure. Well, thanks for those questions, Dr. Natevi. I think, in my opinion, it's my opinion, especially after reading, Dumas et al. Moving the needle, that probably an IO should be the first vascular access attempt in this type of critically ill trauma patient. So because of that, I do think that people should initiate their resuscitation using the IO. And I think that doing like a case report, if your next bad trauma victim comes to the hospital, EMS puts an IO, starts resuscitating the patient. I think that then using that IO to facilitate a peripheral IV, a RIC, or even a central line should be attempted. I'm in the middle of moving, so I'm not really seeing patients right now, but I would love to do it. If it would be me, that'd be great. If it would be any of you guys, I would welcome that too. So yes, in an adult, I certainly think that should be attempted. I don't see any harm in trying that. In pediatrics, I don't foresee a reason why it shouldn't work. Pediatric patients have been getting IOs sometimes more frequently than adults, but so I think that it could work in them too, and I don't foresee a reason why it wouldn't. I also, though, can't speak to time or volume requirements to engorge or optimize their vessels either, but I would imagine that it might even be quicker due to smaller size based on what we saw in our study.
I'm glad to hear that answer. We have a lot of folks here. We have folks on today from Dublin. We have folks on from India. We have people joining from all around the world. I would love this is a topic, obviously, that really prompted a lot of people to join. Is there anyone in the audience who wants to make a comment, either very pro or is someone very against this? Anyone have any other comments before we switch over to Dr. Pepe's webinar? I mean, I see a lot of good names out here who I'm sure want to make a comment.
Peter, if I may to throw in a couple of my thoughts and comments.
Yes, Steve, go ahead.
So following this process and being part of this this quite remarkable study, looking at one key thing that would make the differentiating factor for me is can I readily get venous access? Obviously, if I can, then this is really much a non-issue. If I see a big AC vein or a big interns vein or something like that. Going back to Tanner's point with regards to resuscitative medication, specifically drug like amiodarone and the two papers that you just sent out, we typically, unless we don't see a vein that's readily accessible, we just put an IO in the distal femur to start the resuscitation going. And that was the whole premise behind Dr. Dumas's paper, was that commencement of resuscitation was just taking too long, because it was taking him too long to get central or peripheral venous access, which is where this concept was born from. Would I do this with a 20-minute transport? And the answer is no, I wouldn't. Because I've got a 20-minute transport. Would I do this if I'm resuscitating somebody in their living room? And our of course, just like many other agencies, we don't rapidly transport with CPR. In fact, we don't transport with CPR at all. As I'm getting further into that cardiac arrest, maybe I'll get an IO initially to get some fluids going. But obviously, amiodarone would not be one of the first drugs I'm going to give, even if you are in a shockable rhythm. So maybe that would give me enough time to bridge to a vein to be able to give that amiodarone, and later on, if necessary, some vasoactive medications and so forth. The real place where I see this benefiting the most is going to be, as Dr. Saab said, prolonged field care, really, really long transport times. And in the trauma bay, when patients come in, I like that word that Tanner used, was it hemiplegic?
Vasoplegic.
Vasoplegic. I like that word. I've never heard it before. I'm going to start using that. That's where I really see this particularly being helpful. So it's going to be up to somebody to pick up the ball and say, hey, let's give this a try and start collecting data. but I think we're on to something here, and I think it has some applicability in a number of different settings. Just my 2 cents worth.
Well,
Yeah,
I
this is
agree with your two
excellent.
cents, and you definitely said everything that I wanted to say, but much more eloquently. Thanks, Steve.
Well, no, I 100% agree. And the nice thing is that, your paper was just published. We already have it up here. You're going to have, I'm sure, thousands of views of this. And then I can't wait to hear the feedback from the field when this happens in real people. I see we have Mark Peel here, the creator of the Life Flow. I mean, it's just
Oh yeah.
nice that the EMS community has risen up. Interestingly, I've seen a lot of registrations for today's webinar from the Teleflex people. So there's a lot of Teleflex people here. But Mark, before we move over to Pepe's webinar, do you have any comments? Because I know you spend a lot of time in the cadaver lab as well. Any thoughts?
No, no, and thanks for giving my disclosure. So obviously I have a bias here, but it's what we've seen in years of cadaver models is that you can readily make the vein visible and cannulatable with a small bolus of fluid given quickly. And to address the pediatric question, so if those of you who don't know me, I'm a pediatric intensivist, so I've struggled over hundreds of central lines in kids that are difficult. And in a child in shock with a 1 centimeter femoral vein with no pressure in it, it sure helps a lot to get an infusion of fluid or blood going below the level of that vein. And so this is a brilliant technique. I've actually never done it myself in a child. I hope to try soon. But I've observed in infusing blood through the IO in the femur or the tibia that we really open up that central vein and makes it much more cannulatable. So thank you everyone for doing the study and for presenting it so well. So and thanks for inviting me, Peter.
And before I give Matthew the last word, this is from a guy, Mark Peel, who on YouTube has
Yeah,
himself
I was gonna
drilling
say.
his own bone. So maybe, Mark, you could do a follow-up
Put my
and
own
you
central
can
line
have
in.
someone.
Yes.
Yes. That's what we want to see. Or maybe have Miramontes do that. So let's go to Dr. Saab. We'll give you the last word. You have a lot of people on this call. A lot of people are going to be watching. What are your final comments regarding this topic? And again, thank you so much for joining us.
Well, I believe in this topic. I think that that it's something that we've potentially even been doing without knowing for a while. The patient comes in with the IO already in place. And I appreciate what everybody had to say. I hope that I could answer everyone's questions. I believe in this protocol, and I think that it could be helpful to patients in the future. So I'm excited to see if anything, if we're able to say that it does or not. But thanks for Dr. Peel. It's good to see you again. I appreciate what you had to say, especially about the pediatric patients. And yeah, I was going to give a plug for his YouTube video too. Somebody sent it to me one time and I said, oh, I actually know that guy.
And then let me pass it over to my co-host, Tanner. Any final comments before we go over to Dr. Pepe?
So and I don't want to delay anyone from jumping over to the other webinar. You did use I believe radial access for one of the sites in the study. And while we were talking, I went over to the Teleflex website and looked at like EasyIO approved sites, and I didn't see it listed on their little man figure there. So just
right.
I was curious if you had any thoughts on that. I've never seen it done. I know it's not in West Virginia state protocol, so I was just curious what your thoughts were on that.
Yeah, absolutely. So you're right, and you probably noticed. I don't believe that in adults like the distal femur is listed, or maybe it's in
It's not.
kids.
It's not.
If I have that
It's not.
yeah.
But it's coming soon. It's coming soon.
Right.
Yeah.
Right. So the reason we did that was kind of how I said earlier. We wanted to show that this could be done both in central and peripheral vessels. More peripheral IVs are placed in the forearm than really anywhere else. So we wanted to show that we could do it in the forearm. I understand that it's not in the protocols and would be in really anywhere and would be considered odd wherever if somebody were to see a patient with a radial IO. However, because we were wanting to see if this could be used in such military settings and settings where sometimes you have to go there and do something that's a little outside the norm to help the patient. We wanted to see if this could be done. I will acknowledge that the radial IO had the higher failure rate in insertion in our study. there were a couple of reasons I pointed out. In one patient, they ended up actually, we were able to see, you know, in a couple of patients, we were able to see extravasation because we either went through the radius or not. So it did have a higher failure rate in insertion, but it's been described in literature in the past. And in fact, actually, I think sometimes hematology physicians and oncology physicians draw bone marrows from the radius. So that was
It
why
should
we
also
did
be
it.
it should also be known that when Dave Wampler and Miramontes and all you guys did that study in the distal femur in adults, that it was never FDA approved there. And many people know Teleflex,
Exactly.
I hear, and again, I don't have any insight, but apparently there's a 65 green coming out with that FDA approval to go for the adults. I'm not sure if anyone from Teleflex is on who can either agree with me on that, or if they're not allowed to say, I'll give them a few minutes here to say that. But I agree with Marv. We use any port in a storm. So that's well said. If we have no choice, I don't think anyone is going to have a problem with that. So, but it does. Listen, I mean, there was someone on social media. It was a nurse who said she used the word inhumane. This is, and of course, a critical care medic came and put the kibosh on that and said basically it's not
Yeah.
inhumane. It doesn't really hurt. They should have sent Mark's video on that one too. But you know, I'm
Just
sure
the
you're
one
going to hear
caveat
that.
is the infusion hurts. That was the point of the video, is I had to give
Mhm.
myself some lidocaine into the bone marrow to make the subsequent infusion tolerable. So in your semi-awake patients, I do recommend lidocaine, but that's Peter, a separate topic for us to do a webinar on
Yeah.
someday. Yeah.
Yeah.
100%.
I hope that whoever considered the GAHP protocol being inhumane was on the webinar, so they could better understand the indications and how it works, or potentially read
Yes.
the paper.
Yes, I'm definitely going to post that back on that thread. So, all right, well, let's all get over to Dr. Pepe's webinar. Dr. Saab, thank you so much. Good luck with the move.
Thanks, everyone.
And you're welcome back anytime on the webinar. For myself, for Tanner, thank you all for joining. We have people lined up through almost the end of November now. So the webinar is gaining a lot of steam. So if you see a paper out there that you think you would want to hear from the author, just send me the paper. I'll invite them. Henry Wang just agreed. He just published a great paper in JAMA yesterday. He already agreed to join the webinar. So myself and Tanner are curating the web. So if you find other folks, let us know. And in the meantime, have a great weekend. And thanks for what you do. Stay safe, everybody. And bye-bye.
Bye.
I'll stick around for a second until everyone sees the link in the chat to Pepe's webinar. And then it's just above there. And CME codes have been posted as well.
Thanks, Peter. Great job as usual.